Right, I am going to hand over now to Sally Lawson, Community Nursing in Sexual Health. Hi, Sally.
Hiya. I finally got everything working, I think. If there's some feedback on the sound, I apologise. It's the best I can do. But so I'll just kick off then. My name's Sally Lawson. I am the clinical lead nurse at Integrated Sexual Health at the City of Coventry Health Centre. I've been a nurse for very nearly 25 years. I started my nursing as a mature student when I was approaching later years, and had 5 children under the age of 12 when I went to uni. So it was hard work, but I got there. I worked first in Birmingham in the sexual health clinic in Birmingham for 5 years, and that gave me really the foundation that I needed to carry sexual health through to Coventry. So I've worked in Coventry for 17 years. It was quite hard coming to Coventry because at that particular time, and it's very different now, Coventry was almost in the dark ages compared to where I'd come from, which I found quite hard to adjust because I was used to working very quickly, seeing lots and lots of patients every day. And when I came to Coventry, it was a totally different kettle of fish. Sexual health was so far behind in terms of progression, and what sexual health nurses were doing here were basically chaperoning with doctors. They weren't holding independent clinics, they weren't autonomous, they weren't taking blood, they weren't doing anything that we do now. So things have changed a great deal. I mean, when I first did my training, I was told, you've got to go and work on ward. And as a student, I like nursing, I love patient contact, but I don't like ward work. Now, so many of us have got very different ideas about nursing that I think that there is so many areas of nursing that you can go into. You don't have to go and work on a ward when you've done your nurse training, because the speciality that I work in, it's held my interest for nearly 25 years. Now, for becoming a nurse, the longest I held any job was 4 years. So for nursing to hold my interest for 25 has been great, to be honest. And I've done such a lot. When I first came to Coventry, as I said, there was not a lot going on in terms of nurse development. And it's together with the team that I work very closely with now, the senior management team, we all started around the same time, and we put a lot into developing the nurse role within sexual health. So during my time in Coventry, so that's 17 years, I have gained 10 grandchildren, which is a lot. And the nurses here do an awful lot of independent clinics. Nurses don't chaperone with doctors anymore. We have a brilliant HCA team who do that. They also have their independent clinics where they see patients who are asymptomatic, and we do asymptomatic screens. HCAs do that. They do the blood clinics. We take blood from patients all day, every day. So anybody that works in this department has to be trained in venipuncture. And they come, if they're not trained in venipuncture, they are trained very quickly, because it's an essential part of the role, basically. The nurses then go on to do the genital urinary medicine training, which is in-house training, but it's supported by the BASH competencies, which is the British Association of Sexual Health and HIV, and they have put together a course called the STIF course, which is a bit tongue-in-cheek, bearing in mind the speciality we work in, but it stands for Sexually Transmitted Infection Foundation course. So we all do that course to begin with. Once you are signed off and competent within sexual health, you then do your contraception training. Now, when I did my contraception training, about 8 years ago, I think. It was Forsyth University, Coventry University, which is a full year doing 2 different modules, obviously the academic side and then the practical side. And then once you've got that training under your belt, you then put it into practice within the department, and we all support each other. And even when you're what we know known as dual trained nurse, which is sexual health and contraception, you can then develop further into further fields within contraception. I am an implant fitter, so the contraceptive implant that goes in people's arms and fit those move, and also oils that we use for contraception and emergency contraception. I do that as well. So there's a lot of scope to progress through, not really the ranks, but in the skills that you can gain working in this role. It is great. I mean, we see patients from 30 to 90. Now, a lot of people think that it is against the law for under 16s to have sex. Whilst the law says anybody under 18 is a minor, there is a thing called Fraser competence that we use within sexual health a great deal. So that anybody over the age of 13, if we deem them competent in as much as they know what they're doing, they have informed their parents or carers that they are acting in a safe way, either using contraception and condoms, because obviously not all contraception is a barrier method, so that still leaves them open to contracting any sexually transmitted infection. So we spend a lot of time with the 25s, the under 16s who are over 13. We see a few, and their parents never know, because as long as we deem them Fraser competent, we don't tell parents, because it might be a young girl, for instance, who is in a relationship. She has the mind, I wouldn't say the mind, but the thinking of somebody who is over 18. But purely by their age, they are deemed they should be in a sexual relationship. I've seen lots of couples who are 13, 14, 15. They come together and they are, if you like, far more advanced and savvy about sexual health than somebody who's 18 or 19. So just because somebody's age is saying, oh, they're very, very young, they shouldn't be doing this, doesn't mean that they don't understand what they're doing. So we have very different people coming in, people with physical disabilities, learning disabilities, and cater for everybody basically. We have a lot of sex workers that come here. We go out and see them to provide contraception, to provide sexual health screening, treatments, condoms. We have a lot of people that come in who have been sexually assaulted, who self-refer, or the police refer them, or the support services for people who have been sexually assaulted refer them in. Very often that means discussing emergency contraception if somebody's been sexually assaulted and the male assailant hasn't used a condom. Sometimes they do, sometimes they don't. We also get male sexual assaults, so it isn't just women that are sexually assaulted, men are sexually assaulted as well. I'm quite happy to take questions now. I mean, just to let everybody know that we didn't stop during COVID. We carried on seeing everybody. So emergency contraception was very much still available during COVID.
So Sally, when you're going through the different patients that you're seeing, gone are the days where you're open and welcoming lots of different patients, and especially those ones that have been abused or in any situation. So a lot of mental health training must come in. With when you're working with these patients, not just about giving them some medicine and seeing them on their way.
Yeah, I mean, we all of us here, we're obviously working for a mental health trust. So mental health training is very much on the agenda, I think, for the whole trust. So sometimes we feel a little bit overloaded with mental health training because not all of it applies to our department. We do a lot of training, like I've talked about, the stiff competencies and the BASH competencies. So I think that we are adequately trained to see mental health patients. If we ever think that we need help, we ask for it. And so we all do the DOLS and the Mental Capacity Act training, and we have a couple. I think we've got 3 nurses that are doing the MCA masterclass, because obviously we're all different and we've all got special interests in different things. So the nurses that do have a special interest in mental health are taking that training a little bit further for themselves.
Gosh, it's really interesting. So what made you choose sexual health as your speciality?
When
All those children.
Yeah, I thought, I've got 5 kids, what on earth's happening? How did that happen? No, they were all very much planned, I assure you. Really, the honest answer is I had done my nurse training. I wanted to be a midwife, went for the interview to get onto the midwifery and didn't get the job. So I was left with these 3 years of training. I'm now a nurse, so what do I do with it? So I looked in the Birmingham Evening Mail, as you do when you need a job back in the day, and there was the job at Whittle Street Clinic, which was the sexual health clinic in Birmingham. I went and had a look round, thought, this looks okay, I could do this. And the rest is history. I loved it so much that I'm just hooked, completely hooked. I couldn't imagine doing anything else.
I imagine you get a lot of satisfaction out of your job, out of your role.
I do get a lot of satisfaction because you can get people that come in who have been in a long-term relationship and they have been cheated on, and they are absolutely devastated because sometimes people are left with infections like herpes, which is with you for life, and it devastates people.
Of course, yeah, absolutely.
So to help them and to put a perspective on what they've gone through is very satisfying. When they walk out of the door, they have a smile on their face and they say thank you. It means a lot.
That's amazing, Sally. And I really liked it when you said that you had a look round and then chose sexual health. So within the trust, we really do set that up for people to get into their careers. So even though when we recruit our apprentices, we get them to go on taster days, because it's all very well attending an interview that might not even be where you're going to work. It might be at the head office. You never actually see the patients or the team you're going to be working with. So we absolutely insist that people have taster days in where they're going to be working, either 2 days or 1 day. So I love that actually worked for you those years ago. Then it became your chosen career. So I think that's a really good point, Sally. Emma, you've got something you want to say?
Yes, I was. Thank you so much, Sally. That was really insightful to listen to, and clearly you're passionate about your career that you do with sexual health. I mean, I'm just intrigued to see, is sexual health services, are they on the increase because there's an increase in sexual disease and infection, or is it just becoming less taboo and people are accessing this service more because we're providing it?
There's not been an increase or a decrease. Well, no, it's not really an increase because it is constantly the busiest place I've ever worked. There is always, by human nature, we're all human beings, so people have sex, and it goes wrong for people. And even if people, like I've said, think they've been in a long-term relationship, it doesn't mean that their partner is not going off somewhere else or seeking affection with other people. You know, sometimes people come in and they say, I don't know how it happened, but I just ended up in bed with somebody. And it's there is a knack to getting someone to tell you their innermost secrets, if you like, very quickly, because we can't give them 3 hours of our time, because we have constantly more people that want to be seen than we have staff that can see them.
So I mean, like, that's just, yeah, phenomenal, and it just shows how vital this service is and how much we need to keep it, and how much we need to make people aware, our new talent and our existing talent, you know, how we can get into sexual health nursing, you know, because it links into mental health as well as physical health. But you said you trained as a registered nurse?
Yes,
and then went from it through that pathway.
Yeah.
Yeah,
I mean,
that's great.
For new people coming in, several of our staff have interviewed 2 and 3 times before they've got a job here, because I know that we've got a good reputation around the trust. It is a lovely place to work. We do work as a team, all of us. We're not perfect. We all have arguments, same as everybody else, and we disagree with each other, but we move forward with the majority. We put everything that we're planning to the team to see what everybody thinks, because all the good ideas don't just come from managers, they come from people doing the job. So we always ask everybody's opinion when we're changing anything or planning anything different. Next week, we're actually starting back our open access service, where people can just walk in the mornings. It was total open access and appointments before COVID, and obviously during COVID we had to shave things back to actually who was coming through the door. So anybody who needed to be seen was still seen. We just didn't have that open access where we've got a massive waiting room full of people waiting to be seen all day. Because we do online testing for HIV, syphilis, chlamydia, gonorrhea, and people can order a test online at home, do it at home, send it off, and they get the results within a couple of weeks. So if anybody got a positive result, then we get them in, get them treated, get them into the system if it is HIV, because they will be seeing us a lot. We just deal with people like that. There's a lot of avenues. We go out to universities, colleges to do open days, do subcontracting for local pharmacies that provide emergency contraception for us on our behalf under a contract. Trying to think. There is a lot of things that I probably forgot as well.
Yeah, the skill set, what you described, I mean, you know, just going in as a general nurse and then obviously learning about inserting various contraception devices or whatever in the arm and the other places, and all the, you know, doing the venipuncture and all that. I don't know, it's just like people's knowledge and awareness of all that. You don't think, you just think that you train and you already have all those skills, but you're actually learning and building on it, which is quite interesting.
Yeah.
You know, it keeps you on your toes.
Yeah. I mean, people probably wouldn't believe it, but I already knew a lot about contraception before I started. I just chose not to use it for about 12 years.
Well, thank you for answering my questions, Sally.
Thank you, Sally. Faith, I can see your hand up. Have you got a quick question?
Yeah, so it was just really quickly from myself. First of all, I just want to say thank you for giving such an honest and open insight into the sexual health services, because it's not always that we do get that, and it's nice to see it on the other side, rather than obviously people being patients of sexual health services. So that was really lovely. Thank you. And the other thing that I just wanted to say was, is there any advice that you would give to anybody who is seeking or is considering a career within sexual health service, or a sexual health nurse?
Yeah. come and talk to me. If somebody is really interested, we don't have any vacancies at the moment, although we are interviewing for a band 2 next week. The jobs come up occasionally. It isn't an easy place to get into. But if you show an interest, and have to be really passionate, because it is really specialised. And once you come into somewhere, not just sexual health, but anywhere that is really specialised, and there is so much to learn. There is always more to learn. I've been doing this for 25 years. There's still more to learn. Brush up a little bit on sexual health and contraception, HIV. Show that you're passionate about coming to work here, because we do keep names, and will email people back if we've got a job available to alert that the job will be available. Because as I've said, we've certainly got people, just trying to think, there's 5 people that are on our books at the moment who have interviewed more than twice.
Wow.
Before they've got in. So if somebody comes for a second interview, that demonstrates they want to work here in this speciality. So people like that are invaluable.
That's great. Brilliant. Thank you so much, Sally. That was a really good insight. Thank you so much.
Thank you for letting me talk.
Right, I'm going to hand over to Jessica Ratcliffe now from Community Learning Disability and Autism, Children and Young People. Hello, Jessica.
Hiya.
Hiya.
So I'm Jess, and I'm a clinical educator. I'll give you a little bit of background about how I got to the role that I'm in now. So I did my 3-year degree, and then I went and worked on a gastro ward in the hospital. I worked there for 2 years. Then I got a promotion to a band 6, which I did for a year. Then I got a little bit bored of ward life, so I went and worked in the emergency department for 2 years. And then I decided that I wanted a bit of a better work-life balance, and I wanted to move into like an education role. So I moved into my clinical education role that I'm doing now. So there's 4 of us in our team, and we cover the children's community nursing team, who I think you've got a couple of people coming to talk to you about that team, so I won't go into too much detail about them. We also cover the school nurses, so the team that Vicky's in, who spoke earlier, and we cover continuing care as well. So that is children with complex needs, and they very basically go to a panel, get given funding, and we train carers to support them going to school. So that's children that have got really complex needs who need a one-to-one carer to go to school. Our team will train them up on things like tracheostomies, feeding devices, any like specialist medication they've got. If they have seizures and they have specific like rescue medications, we'll train the carers how to give those. We'll go out and do the shifts with the carers until they're happy to take them by themselves. And then we'll also get referrals from the community nursing team. Say they've got families who the children are going to nurseries, or parents want to go away and there's aunt and uncle that need training how to use a feeding device. We'll go out and do the training for that. And I've run study days for the qualified staff as well, and I've been working on doing some competency work for the qualified staff as well, because the role previously was all about the band 2 and band 3 carers, and we've started to sort of move into more training of the like nurses and people like that as well. And we also cover the Birches Respite Centre, so the carers that we work with who are in the continuing care packages, most of them work at the Respite Centre as well. We do have at the minute just one continuing care package for a child who doesn't go to school, so we provide care in the home for him. And then we train them up so that they can look after children that come into the respite centre. I think that's about it probably.
Jessica, could you explain a continuing care package, please?
So they go to a panel, and they basically explain what their needs are, and then this isn't something that I do, so I don't know all the ins and outs of it, but
Okay.
they basically explain what their needs are, put a case together, and then they will decide what funding they get and what sort of support they need. So like I said, one of our children gets support in the home, so he has carers go in and they'll do night shifts and look after him overnight, because he's on a ventilator overnight, so he has one-to-one care overnight, and he has daycare as well. And then some of them they've got artificial airways, so tracheostomies or nasopharyngeal airways, so they need somebody one-to-one with them to enable them to go to school, because without that funding they wouldn't be able to go to school, because the teachers or whoever wouldn't be able to support them in school.
So what did you train as then, Jessica?
So I'm a children's nurse.
Children's nurse. Okay. And you said you worked on the ward
Yeah.
at first. So was that Warwick or Birmingham Children's Hospital?
That was at Great Ormond Street, and then I worked in at Birmingham Children's.
So what made you think about children's nursing over adult or over learning disability children's nursing? Why you choose children?
So I think I always wanted to work with children, and I was like, oh well, I could work in a nursery, I could do this, could do something else, could be a teacher and all of that. And then both of my parents are nurses, and it was just like, oh okay, well maybe I'll do that. And actually I was really interested in learning disability, but I decided, oh well, I'll go for children's, because then if I decide actually I want to work with children with learning because I would have wanted to work with children with learning disabilities, not with adults with learning disabilities. So it was like, if I go into children's, there's still the opportunity then to work with children with learning disabilities, which is where I've sort of worked my way into now anyway. And like so our team's 4 people. One of the clinical educators in our team, she's learning disability trained. Her background is learning disability. So it's like people were saying previously, there's lots of different routes that you can go with whichever speciality you go down, really.
And would you do it again? Would you do this? Would you do that again? Would you do the same pathway?
Yeah, I think so. I think it's been really good experience, and everything that I've done has really helped with the role that I'm in now. And in terms of working in the more education side of it, I wouldn't have been able to do that if I hadn't had all of the other experience that I'd had, and I wouldn't be as good as I am at doing what I do now if I hadn't had those other experiences.
Yeah, it's really hard to lead a team and provide advice and guidance to a team when you haven't actually done it yourself. It's difficult, isn't it? You need to have done it and started at the bottom and worked all the way up. So yeah, no, I absolutely agree there, Jess. So in all of the roles that you've had and all the jobs you've had in children's nursing, which one would be your favourite, do you think?
I think at the minute it's the one that I'm doing now. I think it's definitely more the side of it that I wanted to work in, was the more education side of it, and that's from a personal side of things. Particularly when I was a student, I had some quite bad experiences with the people that were training me, so I always sort of was like, oh, I'd really like to go in and do it properly and give people the support that they need. And be somebody that is supportive to other people, because everybody needs training. There's stuff that everybody can learn, and I'm not an expert, and I learn from people when I'm training them. And that was definitely a good part of it. And I've got a baby, so at the minute the work-life balance that I've got is perfect at the minute, because I get to work 9 to 5 Monday to Friday. Like it is really good.
No, absolutely. And I suppose the last question I have then is, what skills do you think or experience people need to become a children's nurse? If they're choosing children's nurse as their pathway, what are the skills do you think they need?
I think really it's the same with any pathway that you're going to go down in nursing, but it's things like you need to be resilient. Lots of people, even my friends that are nurses that aren't children's nurses, they say, oh well, I couldn't work with children, it's too heartbreaking. But you have to take those heartbreaking moments with the amazing moments that you get as well, and it's about that balance. But you definitely need to be a resilient person, but you do in any field of nursing. And I also think, like, when working with children, something that I've found makes that easier is just being a bit silly. Don't take yourself too seriously. That's what children are going to lean into more. That's what's going to make them come to you and feel supported by you.
No, absolutely. And it's really important what you say there, that it's all about, it is very heartbreaking, but someone's got to do it, and if you didn't do it, who's going to? So these parents need the support of a brilliant children's nurse to look after their children. So absolutely hat off to you, to Jess and to your team. Thank you so much for today. It's been really interesting. Thank you so much, Jess.
That's all right.
Right, I'm moving on because I'm noticing my time is moving on. So I'm going to hand you over to Nikki Elliott, Service Manager at Palliative Care. Hi, Nikki.
Hi, everybody. Nice to meet you all.
Hi.
Hiya. Okay, so I'll just start a little bit, I suppose, about me, what I did, and how I got to where I am now, and a little bit about palliative care. So I actually started with this trust 22 years ago, and I started as a healthcare assistant, and I was seconded to go and do my nurse training by the trust. And then several secondments later, I did a specialist degree with them. I did a master's degree in leadership and management, did my non-medical prescribing, and came into palliative care 8 years ago, having been a sister in district nursing. Palliative care is my passion. It's where I've always wanted to be. I'm now service manager at the moment. As a team at the moment, palliative care is moving in big directions. We have had lots of funding from government to expand our team. We have certain government and NHS England guidelines that we have to meet, and part of them, that is 7-day working, providing specialist palliative care 7 days a week, 8 a.m. to 8 p.m, and also providing a rapid response urgent care for palliative care as well. So that has happened quite quickly over the last sort of 8 months. All these things have expanded. So our team, we're currently out to advert for lots of vacancies, because our team is growing at the moment by the day, which is fantastic. And more to the point, it's fantastic for the patients of Coventry, because the service that we're able to provide now, we have a team of band 3 healthcare assistants that look after patients in the last 2 to 4 weeks of life. They provide hands-on care, basic wound care, pressure area care, that sort of thing. Then we have a rapid response palliative support team that consists of band 5s and band 6s and some band 4s now that we're just recruiting to, which is brilliant. Again, for us, it's all about developing our own, getting them in, supporting them, really good development packages, and trying to make sure that we can build our own staff, and our own specialist nurses out there. So that's a really good thing that we're doing at the moment. We then also have a team of band 7 specialist CNSs. So there's 8 of them. They're all non-medical prescribers, and they look after the complex patients, the patients that are really struggling with symptom management, don't want to be in a hospice. They look after those really struggling patients, and they case manage their patients, so they're planned care. We are a really good multidisciplinary team. We also have therapy, so we have an occupational therapist, we have a physiotherapist, and a technician at work with them, and we are very shortly going out for a band 6 therapist as well. So that side of our team is growing with the rest of the team. We're very fortunate that we have a clinical psychologist for our patients, but also our band 7s, because they have to be level 2 psychology trained, they get psychological support from our psychologist as well, which is really good. But most importantly, we are consultant led, so we have our own palliative care consultant, and we have a registrar that sits with us as well. So we're quite a big team, and we're a really good multidisciplinary team, and I think that's important, because with palliative care you only get one chance to get it right, and I'm very passionate that we do that, especially to everybody that lives in Coventry, because there is such a variety of diversity and patients out there. We have good access to our language line. We use lots of different things to make sure we can look after the whole of the diverse population of Coventry.
Yeah.
Very whistle stop tour, but there you go.
So that's great, Nikki. Would you mind just taking us back a little bit about what palliative care is, where the word comes from, palliative, etc., the kind of things we have to do to make our palliative care really great for our patients?
Okay, so palliative care is basically it is for any patient that has a life-limiting, non-reversible condition. And palliative doesn't need to be last days or weeks of life or hours of life. It can be months, it can be years of life. And it's not all cancer patients. We deal with a lot of malignant and non-malignant patients. So we see a lot of COPD patients, heart failures. We work a lot with collaboratively with different specialisms out there. So things like our COPD team, our heart failure team, when they become sort of more symptomatic, we work very closely with them and give them advice, and vice versa. If they're not underneath them for some medical reasons, they assist us and give us advice as well. We see a lot of dementia patients. So it is a very broad spectrum palliative care as to what we see and what we don't see. We don't just see every palliative care patient in Coventry. So district nursing, we work very collaboratively with them. We provide education packages to our district nurses. We also work very closely with the urgent care response team as well, because they will provide anything that's what we foresee as acute and reversible will go to that specialism. So it is very much about integrated and collaborative working to make sure that our patients are getting the best care. So it's the right person delivering the right service at the end of the day, which is what we try to aim for. Does that answer it?
Yeah, that's great. No, that's great. And can you tell me what occupational therapists and physiotherapists might do when they're working alongside you?
Okay, so our physio and OTs are very specialist in what they do. So we don't do rehab, because obviously our patients are not rehabable. It's about quality of life. It's about giving our patients the best in the limited time that they've got. So, whereas a lot of occupational therapists and physios will work on sort of like getting people up and walking and things, for us it's concentrating on what's most important for that patient. And sometimes that will be things like just getting them in the garden, being able to get them from a bed into a chair, into the garden, controlling their breathing. Again, it's not all about medication, although we've got experts in field of medication symptom management. Our physio is very trained in breathing exercises, teaching people about breathing, and things like that. So it's a very varied job for them, but it is very specialised in the fact that they are concentrating on quality of life and how they can improve what time they have left with their loved ones and where they want to be, and making it safe.
Amazing. So Nicola, to become in palliative care, then you would do adult nursing?
So yes, we are an adult palliative care service. So our patients are purely adults, so it would be adult nursing to come through to us. Our trust does have a community children's palliative care side. Yes, I can see you there, Amanda. We met a couple of weeks ago, which are absolutely excellent. So there is that sort of, you don't have to be an adult nurse to come into palliative care. You can go into palliative care as a children's nurse, but obviously for our service, we are the adult side. And there is a big difference.
So you would do adult nursing for your side, Nikki, and then you would do children's nursing into Amanda's. I see. Okay,
yeah,
that's
yeah. So we work a lot with families, young families. So we're very, your DBS checks, all that have to be very up to date, and our safety, I can't speak now, but our training has to be very up to date as well, because we get a lot of young mums and dads that are sadly dying, and there's children, so we have to know a lot about children bereavement services and working alongside those children. We work alongside social services a lot as well when it comes to young families and things. So and then we work alongside like continuing health for our fast track patients and things. So it's we have a very good working relationship with all our services out there. But yeah, it is adult palliative care that we deliver. So it is that we do take newly qualified staff as well as substantive staff. As I say, we've very much brought new levels of staffing in now to try and so that there is a development process within our team, which before was very restricted when we were just a specialist team, whereas now, because we are the palliative support integrated rapid response team as well as the specialist, we've got lots of development opportunities. So we have grades from 3 all the way up. We have a couple of our girls, we've just taken on one of our band 4s that's just completed the training. We've got a couple of our band 3s that are going off to do the training in January. There's lots of our band 5s. We've just developed a new band 6 specialist post, and we got 6 vacancies, and 4 of those were our Band 5s internal development. So it looks like we've got lots of Band 5 vacancies now, but that's through internal development, which is brilliant.
Oh, that is brilliant. That's great. Thank you so much, Nikki. That was really interesting. It's the first time we've had palliative care on our sneak peek. So thank you so much for coming, Nikki. It was really, really interesting. So thank you very, very much.
No,
Thanks,
you're
Nikki.
welcome.
Thank you. Right.
Thanks.
I'm going to speedily move over to Amanda, if that's okay, Amanda.
Hi, you're right. Hi. Yeah, so I'm Amanda. I was going to be joined by my colleague Anna, but unfortunately she finished us early on a Tuesday. She's had to go. So yeah, I'm Amanda Parsons. My current job is I'm the clinical lead for the Children's Community Nursing team. I'm glad I've been able to hear Jess, so I won't repeat a lot of what Jess has said. But I'll give you a little bit my own personal journey. I qualified as a nurse more years ago than I care to admit to. Trained as a paediatric nurse at Sheffield Children's Hospital, and what led me to that was I always wanted to work with children, but when I was about 16, I read a book, and it was called 5.5 times 3. And it was about a little boy who died of cancer at the age of 5.5, and the times 3 was his mum and his dad, and it was him. And it was a book written by the parents as a gift, as a message to the child. And I think once I read that book, it was children's nursing I wanted to do, and at some point oncology nursing, which I did. So yeah, trained at Sheffield Children's Hospital. My hospital career has been Sheffield Children's, Birmingham Children's, as I gravitated south, mostly in oncology. I then did a couple of nurse specialist roles, one as a nurse specialist for teenage and young adult cancer, and equally then I did a slight step change and I did a children's respiratory role. But for the last 15 years, I moved out then to community, again, a little bit like a lot of people, a decision driven by family commitments, work-life balance. But I haven't looked back. Community is absolutely where it's at for me, and I'm very passionate about the children and young people that we care for. So I've been very fortunate since I worked here. So like I said, 10 years in community, that's mainly spanned the whole of the Midlands. So Leicester, Warwick, Coventry and Birmingham. I've worked in all those areas and all those cities. So I'm very fortunate. And since I've been here now for 3 years, and I'm currently, I came as a non-medical prescriber, but I've currently been given the opportunity to do my children's and young people's advanced clinical practice, which will be a new role for children's community. Mainly advanced clinical practitioners for children in places like ED or acute settings. So I think we're all feeling our way through that one. So I'm very privileged to be the clinical lead for the Children's Community Nursing Service. We're quite a small service in relation to the organisation. So we're a team predominantly of registered children's nurses, mainly at Band 6. We have 9 caseload managers. They're not 9 whole-time equivalents, 9 physical bodies. And they're supported by nurse specialists, by clinical leadership, by ops management, by admin, and a fantastic place specialist who works alongside us. And I'm really hoping I haven't forgotten anybody. And of course, we get support from Jess and her team for clinical education and work closely with the other services. So our real remit, it's always as it ever was since community children's nursing came into existence probably about 30 years ago, is about keeping our children and young people out of hospital. That was the initial remit that we had. That continues very much today and is very aligned with the NHS long-term plan. Nobody should be in hospital if they don't need to. Over those years, we've got cleverer at what we can do. We've developed safer practices. So now there is so much that can be done for these children in community that over years would have been done in hospital. So we have main groups of patients. We have children with long-term conditions and we manage their treatments at home that previously they'd have to go to hospital for. That can be things like TPN, central line management, regular injections, infusions, enteral feeders who need feeding tubes changed. So we have that group. We deal with the chronic respiratory patients like CF and those types of things. And then equally, we deal with children with cancer. We can do some cancer treatments at home now for children, save them going to hospital. And we more latterly, I guess, the biggest workload we have, and wonderful workload, is our children with medical complexity. We're now saving children a lot younger. We're keeping them weller for longer. But with that comes medical complexity, and we look after children who have profound medical complexity, multi-system problems, respiratory, gastro, epilepsy, seizure management, and profound and multiple learning disabilities. So day to day, we deliver treatments at home. The Band 6's caseload manage a group of children. A lot of that is MDT working with physio, OT, social care. So that's the sort of day-to-day bit. The other bit that we provide as specialists in children, really, and in addition to what Nicola said for her service, is we do the end-of-life care for children in the city. So any child in Coventry who decides that home is going to be their place of death, or the family do, then that's the care we provide. At that point, we change our regular working hours, and instead of doing a sort of 8:30, 5:30 Monday to Friday, we work 24/7 and are on call for those patients. So they would ring us direct, and we will visit to do their symptom management. And again, I think that it's something we're incredibly proud of. We're very passionate about. It's very hard to predict when it comes. We don't know how many children in any given year or when it can happen. If we get 2 children in that position at the same time, it can be quite a challenge. We're a very small team, and we tend to go out in 2s overnight as much to check drugs, to manage symptom management, and for anything else, for emotional and peer-to-peer support for ourselves. So we you know, that's the addition. In our regular service, we do a telephone on-call service for families that are on the case, so they can ring a nurse 24/7 for advice around care and treatment issues. So yeah, we're constantly looking to grow and develop. We're constantly looking to expand our services. There are big challenges, and particularly our medically complex children, who can be across multiple consultants, really, and where they're constant, because our speciality is children. I think, you know, looking forward, we are looking at upskilling colleagues. We've got more colleagues doing advanced health assessment. We've got more colleagues hopefully going on to do their non-medical prescribing. We've got nurse specialists who support the team. We have a palliative care nurse specialist, respiratory nurse specialist, epilepsy nurse specialist, and we're always looking to expand our services. But yeah, we're incredibly proud, passionate what we do. We're determined to keep our children at home. No child should be in hospital if they don't need to be. So I think that's us in a nutshell, really.
Absolutely, Amanda, and that's such a passionate way of explaining it. It was absolutely fantastic. So I love that about keeping children at home. So do they have to have special bedrooms? Do you get involved in that and helping them change? I suppose occupational therapy probably get quite heavily involved in that, in changing the bedrooms. Do they have to move downstairs? Like, how do you keep a child at home?
Yeah, the medically complex children now, there is a massive team around the child, and we're supported a lot through, thankfully. In Coventry, we've got a very active children's disability team in social care, so they have OTs attached to them, and obviously we have OTs attached to us in children's services. So you find with your medically complex children, they will be, I mean, obviously my area is in nursing, but they will have, from CWPT, they'll have a physio, they'll have an OT, they'll have speech and language therapist, they'll have a dietitian. They'll also attend one of our special schools and be supported by a special schools nursing team. They'll invariably attend our respite unit as well. So these children are very well known to a lot of services, and we do work hard to try and streamline that care for them as well. But often the nursing role is, you know, yes, a deliverer of hands-on care, but that's why we call our Band 6s caseload managers, because they do take on that liaison, organising MDTs type role, really. I think the other thing that's worth mentioning at this point is we do, like Jess's team, we're finding a bigger role in education, because there's only so many of us to do the hands-on nursing care. But I think we need to manage that with expecting a lot of parents. We expect so much of our parents. They train to do feeding tubes, injections. During the pandemic, we taught parents to flush central lines, to give chemo, to minimise the amount of people that were coming into the house. But I think some of the future is in that, because we have more and more children with things like feeding tubes, and you know, we're not there 24 hours a day. We haven't got the resource to be. So we a huge part of our remit now is in promoting self-care, self-reliance. And equally, now our children are surviving, to come on the radar of adult district nursing and adult services. You know, we need to slightly loosen the hand holding as they get older, really, prepare them for the adult world. So that's another big challenge for us.
Will that be 18, Amanda?
It is 18, but once they're on our books, we tend to keep them. We always have discussions about what happens when we get a new referral at sort of 17, 18, and it would be the same with our palliative care colleagues. If we've got a 17, 18-year-old with a new palliative diagnosis, we'd have to have a conversation about who would be best meet the needs of that young person. But we do work quite closely together, and we're grateful, you know, Heather, who's the Hazel, sorry, who's the doctor for adult palliative care, is available to us. We do have our own paediatric palliative care doctor that supports us as well. So yeah, I think we're getting better at working together, knowing that all these young people will, now we're keeping them well, will become adults at some point.
Yeah, it's amazing. It really is. And so interesting to hear what goes into it. And not only looking after the patient, but the families as
Oh.
well. So yeah, no,
Yeah.
thank you
No,
so
no
much,
worries.
Amanda. Absolutely. Again, another passionate conversation about children's nursing. So thank you so much, Amanda. So basically, this is where we are now, thinking about moving into the NHS and attracting local talent. So one way of doing it is by doing an apprenticeship in various courses. So one of our courses that we offer is lead adult care worker. We can also offer now bespoke qualifications to get people into these band 2, band 3 roles, and we will ensure that it is bespokely written. So if you were to come and be an apprentice in children's, we would make sure there were some children's modules. If you were going to come and work at tissue viability, we would make sure there is some tissue viability modules there. We have at this moment in time apprenticeship vacancies in learning disabilities, mental health, tissue viability and district nursing. So no matter where you are, we've got them in each nursing speciality. So you become an apprentice and you work with us for 12 weeks, and that's where you learn your trade. You have the opportunity to observe and shadow the professionals in action. You will complete something called the care certificate during those 12 weeks and be supported by the Talent for Care team to do that. You will then work as a healthcare assistant, and you will see throughout the trust, healthcare assistants are called lots of different things: support workers, health workers, etc., etc. And this is a band 3. You'll have heard lots of bands been talked about today, and that's all about salaries and where people are and regarding where they are in their registration or where they are in their qualifications. So you work as a healthcare assistant band 3, and you will complete that level 3 qualification. You will then be a qualified healthcare assistant, and the world there is your oyster. You can move on to become a student nurse associate, doing a foundation degree at university. You will be paid a salary, and we will fully fund the university course for you. You're there for 2 years. It is 1 day a week at university. After you've done your nurse associate, we would then ask you to work as a nurse associate for 12 months to really consolidate all of that incredible learning you've been doing over the last few years. And remember, you earn where you earn, and you will work as a nurse associate for 12 months. At that point, you can then apply and study for the registered nurse degree apprenticeship for 2 years. So where you might go to university, which is just as fine, you would go there for 3 years. Here, you would actually just do it for 2 years because you've already got the foundation that you need from the level 3 and the level 5 qualification, which is the nurse associate role. Again, we will pay your salary, and we will also pay your university fees. So you come out with no student debt, which is one of the best things about it. And then you would work as a registered nurse, band 5, in that chosen speciality. So if you're working in adult services or district services, you will do adult nursing or children's nursing. If you're working in learning disability, you will become a learning disability nurse. And again, if you're working in mental health, you'll become a mental health nurse. If you wanted to swap around and you're working in LD and you wanted to become a mental health nurse, then you would need to then get a job as a HCA within mental health. We can't study for a specialty nursing degree in a completely different directorate. So we ask you then to have a real think while you're a HCA, while you're a healthcare assistant, what actual speciality do you want to move into? Faith's going to share with you the nursing pathway that you can print off on your computers. It's a graphic just to show you everything I've just spoken about, and it also takes you past being that registered nurse band 5 role up into band 6, band 7 and band 8A, which is what we've been talking about today. So the HCA level 3 apprenticeships is that you will study for a level 3 qualification. You are 12 weeks an apprentice. You work a 37.5 hour per week, and this would include days, evenings and weekends. You do get paid a little bit more for evenings and weekends. That always helps with the salary. You will attend training sessions 1 day per per fortnight at college, which either be at our place, which is our headquarters, or at the training provider's place, or virtually. 12 weeks, you will be paid national minimum wage for your age. So if you're 18, it'll be the minimum wage for that age. If you're 24, it'll be that age. If you're over 25, it'll be minimum wage for your age. And that's only for the 12 weeks while you're supernumerary and you're learning your trade. At the 12-week mark, you then get up into a band 3 position, which really kind of doubles your pay. So it's an excellent opportunity to get yourself into the NHS. Now, you have to be 18 years of age, and in some apprenticeships, you do need to drive. It's really, really important. Some of our hospital environments, you don't need to drive as long as you can get to the hospital, like the Caldon Centre, St Michael's, or Brooklands in Marston Green. Once you're there, then you will be there, and that's where you will work. Obviously, in district nursing, we do prefer people to drive, as you'll be going into patients' homes. The same for community mental health as well. What I suggest, if you are a young person and you are doing your A-levels at this moment in time, is to really look at finishing your A-levels and then contacting us about apprenticeships within the NHS. You want to go to university to do your nursing? Absolutely, that's wonderful. Keep in contact with us. We'll let you know what roles there are after the 3 years at university. But via the apprenticeship, which means that you will work while you're learning to become a nurse. And I think that is one of the best ways of becoming a nurse. It's a really fabulous opportunity. Any information you require, please contact Talent for Care. I'm sure that's in the chat box of some sort. If anyone would like an individual conversation about their particular career pathway into the NHS, we are more than happy to do that. Please share the information you found today with friends or teachers, etc., or neighbours you think might like to be a nurse. It's really important that we increase our nurse numbers, but we want to get the right people in the role with the right values. So really, thank you so much for listening today. I think we have just about done all of the questions that we need, and I don't want to keep you guys anymore. So I will say thank you so much for listening. Please be in contact with Talent for Care for any information that you need. Look out for other sneaker peeks into psychology, allied health professionals, which is your physio and your OTs, and also into admin. So if you have friends, colleagues, neighbours that are interested in any of those careers, please let them know. Please follow us on Facebook, Talent for Care on Facebook. All of our events will be on there. I thank you so much for attending. It's been a really lovely afternoon, and I thank you very much. And a huge thank you to the speakers today. Could not do this without you. Thank you very much, everybody, and take care.